Cool. Brilliant. Thank you. So the next talk is going to be from Dr. Colin Dunkley. He's going to update us on Epilepsy12 audit. Thank you, Colin.
I think we should have a bigger round of applause for the youth advocates. That was amazing. Thank you so much. And I'm expecting if you're online, you're clapping as well. I'm hoping you don't feel left out. I'm expecting you to join in. And there's no way I'll be wearing a jacket like that. No way, flaunting it at the back. But it's nice to see some new hospitals being built. So I was delighted to see that. It'd be great if we could have like a real 3D tour. Hopefully it'll do a tour, actually, the hospital around different services. So myself and Nikki, we've got 40 minutes with you. I'm going to talk through some of the results from Epilepsy12, and then Nikki's going to showcase some of our work as well. And I'm hoping that this works, so we'll see how. Let's see how we get to it. It feels strange to be face to face, though. Does it feel strange? It feels strange for me. So, how good is your local epilepsy service? How good is it? I did this exercise the last face-to-face conference, and I didn't use Menti. I just got people to put their real thumbs up. So from 0 to 100, and this involves you online as well, not using any buttons or anything, how good is your epilepsy service? Where are you between 0 and 100? Have a think about the good bits, the not so good bits, the difficult bits. How would you rate overall your service? There's many facets to it. It may even be impossible to do, but it's going to be somewhere between there and there. And I think most people are going to put it around like that, something like that. And now another question: how hard are you working from not working at all to working really hard? Yeah, so more people using both hands there. So let's see hands here. How hard are you? Yeah. So I think most of us are working as hard as we can, and supporting young people with epilepsy is really energizing, but it takes energy as well. And we saw it particularly through the pandemic, the amount of energy people were putting into supporting young people with epilepsy. So thank you. But we may be only really feeling how much energy we've been expending now. And one of the dilemmas we've got is, how do we take energy that we're at maximum and put it into improving care? How do we get some of the energy we're using into supporting young people with epilepsy into actually improving services for epilepsy? Where does that energy come from? Some of it's going to come from diversion of energy towards improvement. We need energy from outside our bubbles as well. So I'm keen to think about both where we're at from a quality side of things, but also how do we get to where we need to get to. And I'm feeling both of these things are improving. So I'm feeling that services are improving and there's more energy. So I think we are getting to better places. But as we get forwards, we need to think about where is this energy and capacity and resource coming from, because it can't just come from within ourselves. And I used to think that you could measure quality in quite a simple way. I thought it was about star ratings, and quality was a one-dimensional type thing. But when I started my work with William Whitehouse, who's here in the front, some time ago, he totally changed my view of measuring quality to be a thing you can do systematically and look at multi-dimensional elements of quality. It's not a single thing. It'd be nice if it was. And this is how we started with the Epilepsy12 audit. Over 17 years ago. This was our first form, and William helped me with this, and Catherine Martin helped me take it around a population. But we drilled into specific details of people's epilepsy care, and that's grown to be the Epilepsy12 audit. But it started from very small obsessions with detail in children's lives with epilepsy. So thank you to William and to Catherine for getting this started, for changing our view of quality. It's been quite a journey, and this is where we're at now, some 17 years later, producing annual reports. And this is our latest report that hopefully you're aware of, that came out in July. And we're really pleased with the front cover. It's Flower Garden, and it's been drawn by Janet Lee, who's an artist who's living with epilepsy. And if you try and join the dots up, our timeline for epilepsy, you can see we've been a sort of growing machine. And we're now moving to a position where we're producing data into the public domain every 3 months, producing a report every year, and are able to move our priorities and see change and improvement over time. So this is our latest report, which we'll look into today. And then we're producing trust level reports, regional dashboards, and these quarterly reports now, which Nikki will talk about a little bit. But this gets us towards more real-time, responsive senses of quality. So we're going to dig in a little bit into the report, but I'm just going to essentially give you highlights. So we've been really pleased with participation. This is an England, Wales-wide audit, and we've had more participation and engagement this round than ever before. So most trusts and health boards have taken part in the organisational element of the audit, and the vast majority have taken part in the clinical data entry for the children and young people with epilepsy. So this has been higher engagement and data completeness than we've ever had before. So many thanks. Increasingly, we're finding it easier to find those children and young people with epilepsy as the services become more discrete, and the data we're pulling from them is increasingly just from those with epilepsy. This publication looked at those who had the first paediatric assessment back in 2020, and we like to look at a whole complete year of care before we begin to think about their quality. So we've had 2,300 or so children with epilepsy in this year's cohort from England and Wales, and they've all completed a first year of care. And from those stories of their epilepsy care and their interaction with services, we now have 10 to 12 performance indicators, so measures of quality, and we've been changing and evolving those over time. And this is an overview of all those on one screen, just to make your eyes go funny. So each performance indicator is a gathering of the 4 horizontal bars, and you can see time passing. So from round 3, cohort 1 on the dark top, to pink, which is our latest results. And if we scored 100% in each of the performance indicators, we'd be 100 down here. So you can quickly see the gaps, you can quickly see some areas we're doing well in, and you can see overall that in most areas there's incremental improvement. And to make that easier to see, we've put green arrows next to those areas where there's been incremental improvement. So what I'm going to do now is look at what we thought were the key things to highlight from all this data that we've put into the overarching report. just to give you a feel about what the reviewers, the stakeholders, the young people thought should draw our eye. So the first message we would like to make is around holistic care, and increasingly it's not just paediatricians with expertise and epilepsy specialist nurses that young people and their families need to support them with their life journeys. It's a whole range of people and professionals. The key people of paediatrician with expertise and epilepsy specialist nurse is getting better over time. So most children with epilepsy now are having ongoing access to a paediatrician with expertise, whether that's a general paediatrician or a paediatric neurologist or an epilepsy specialist nurse. So these figures are improving, but there's still a lot of children with epilepsy who are not seeing these key professionals. But the point we'd like to make is that there's other people who need to be in the mix. And this slide begins to show the sorts of things we're dipping our toe into to try and show the range of people who need to be involved. So the number of children within the audit which are known to have a mental health condition, we think is too low. We think there's more mental health problems in our epilepsy community than is being recognised. So we feel it's been under-recognised and under-reported. In our data, we show that 5% had a recorded mental health condition. We think that's too low. Most people with epilepsy have other problems they need to deal with, for example, autism and intellectual disability. But when you go looking for this in the children, it's not as documented in their records as you'd expect. And most services aren't actively screening for mental health problems or screening for the learning difficulties, learning disability and autism and other problems. So we think we're missing other problems in the mix. And only a few services have co-located, embedded, integrated mental health services. It's only the minority. So our recommendations have been really trying to broaden and make clearer the number of professionals around the child and different professionals for different children. And we're challenging local systems to make it much clearer for professionals and children and their parents to find the people they need to find, be signposted to them, and actually have someone they can connect to at the end of that signpost. So I think there's a real need to formally show and connect people to this holistic group of services and professionals. The second key message is around equitable care. We've tended to look for variation on the basis of geography or service and shown massive differences in quality between different services, but we've not really looked for other factors that might be unfairly causing variation. When you look at our deprivation data, the largest quintile is the lower deprivation quintile. So 28% of people with epilepsy are in that 20% quintile. So 28%. So the biggest group of children are in that group of most deprivation. But it varies massively from region to region. So some regions have really high deprivation elements within their epilepsy population, and some have less. So how do those services need to be different because of their different makeup of communities? And I think within Epilepsy12, we've been slow to look at the different aspects. We've been seeing deprivation, but we haven't seen other equity elements. And increasingly, we're building in other elements into our data set, so we can see variation according to ethnicity, to the presence absence of learning disability, and to other marginalised elements. So increasingly, you're going to see data cut to see variation for reasons other than geography. Children and young people go to school, they're in education, It's no surprise, but I think the connection between health and education needs a lot of work. There's not enough people who've got good healthcare plans in school to help them have the education and lives they deserve through school. Somehow we need to do better. Some services are not seeing any healthcare plans for school in their ongoing healthcare. So something needs to be done to shake that up. And I think ICBs, ICSs are in a really good place to try and forge links formally between education and health. And finally, there's some areas that are really stuck. So the graph's nice to look at, which shows improvement in some areas, but these are the areas which just doesn't seem to be any improvement over all the years we've been doing Epilepsy 12. So the right children having neuroimaging, the right children all having an appropriate first assessment when they first present, the right children with complex epilepsy seeing timely neurologists and having opportunities for epilepsy surgery consideration, and the school individual healthcare plans, we're all stuck. So somehow we need to shake up and improve those areas. Why are they stuck? Why are we not seeing improvement in those areas? So again, I think ICSs and regional groupings are in a really good place to try and think what the enablers are for helping those things improve. So finally, before I hand over to Nikki, this is how quality through Epilepsy 12 looks at the moment, but I don't think it should look like this at all. What I think it should look like is more like this. It should be a flower garden. We should be seeing variation, but not because of inequity or geography, but because children need individualized care and they need adjusted care. And then we need to see their outcomes and their outputs. And that's going to look messy and irregular, but it's going to be them living their best lives. So it's not uniform, it's colourful and more like this. So thanks for your time. I'm going to hand over to Nikki, and then we'll have some time for questions. Thank you.
Thank you. Hi everyone. Hopefully you can hear and see me. I am on my toes to try and reach over this. Yes, if that's a bit better. So I'm just going to quickly walk you through some data collection and reporting changes that we've had to the audit recently. So the first slide we've got just highlights some of the changes. So as Colin described, we've got some new 10 performance indicators, our KPIs. So we have had 12 for the past, I think, 4 years, but we've refined these. So we've kept quite a few of them the same, but we've shifted our focus onto mental health screening and support, and also timely access to the health professionals. We've started collecting more health inequality data, so more demographic data on patients' ethnicity, more data on mental health, neurological conditions and learning disabilities. So we're hoping to kind of dip our toe, as Colin said, into those variation in care. Also got slightly different cuts of data, so we're focusing on now reporting at Trust, NHS England, ICB and regional levels, still continue our Open UK regional reporting, and then the country and national of England and Wales. And we've also got an exemption from the NHS England national data opt-out. So all of these changes are kind of how Epilepsy 12 is evolving over the years, but I've highlighted some in pink, which I'm just going to walk through today. So firstly, we've got the frequent reporting in the public domain that we've started. So we've published our first quarterly report via an interactive dashboard in July. So this is online, and we can pop the link in the chat for everyone to access, but I'm just going to walk you through some screenshots of the different outputs that we've got. So these are in the public domain, and they're aimed at health professionals, managers, commissioners, stakeholders, but also to the public, patients and families, to just give an overview of our performance indicators at various levels. So really proud and congratulations to the team for creating this. So what we've got here first is the national view of England and Wales combined results. So you can see the dials of how the performance varies. This is just dummy data for the purposes of this presentation, but you can see the dials with percentages and then the numerators and denominators behind those as well on the table at the bottom left, but also on the top right, I think it was, sorry, you can see the change from cohort 4 to cohort 5, and then you can imagine as we progress through the years, you'll see the quarterly updates, and you can see how you've progressed over time, and you'll notice that a few of them don't have any data from cohort 4 where our performance indicators have changed. So on the left-hand panel, you can see in the light blue the different geographical levels that we report at. I'm just going to highlight a few today. So firstly, this is the NHS England regional view. So on the left-hand side, you can see an overview of all the performance indicators on the graph and the table. But on the left, no, sorry, I'm getting my left and rights confused. On the right, you can select a performance indicator. And once you do that, you can see the variation between the regions there compared to the England average in the light blue line. And then on the bottom graph, you can see all the ICBs within that region for that indicator. So all the graphs will update depending on your region and measure selection. So the ICB and the Open UK network follow the same logic, where you can see the overview and then all the ICBs or trusts within that region you've selected and for the particular measure you're interested in. So then trust and health board level is the lowest level of granularity that we report to in this dashboard. And here you can see an overview of the performance indicators in a similar way. And then you can also see the radar chart. So this shows you your performance for your service against the regional and national averages. And it's just a quite visual way to represent your data and see how you're doing. So this is Sherwood Forest, but it is dummy data. So kind of next steps we've got, we're thinking about ways we can improve the dashboard, so any extra features we can fit in, for example, the total cohort numbers or case ascertainment you're currently on to help track your data entry in the audit. But essentially, this is our little request to please enter your data as frequently as you can and hopefully move to prospective data entry, because the more good quality data that we have in the audit at various points, the more we can put out into these dashboards and the more you'll be able to use them better to track your service, monitor any quality improvement projects you're doing, benchmark against your peers and the national average. And additionally, it's an extra quality assurance step to your data entry. So if you spot any errors that you think your percentages are not right, you can go back to your forms on our platform and make any corrections. So this is available on our website, and we've got lots of extra user guides and demo videos to help you use the dashboard and also help you understand and interpret the data presented on there. So the next part is our new data platform, and I was going to demo it. However, there's a few technical complexities, so I think I'm just going to walk you through our some screenshots of it to show you, and then you can keep your eye out online for a video and the launch of the platform. But so our Epilepsy12 have been creating a new platform. It's been running for a couple of years, and we're hoping to launch it later this year. But just to highlight a few features of the new platform, we're hoping that will be easier to use and navigate to help reduce the data burden associated with the audit. We're going to only collect information on those children and young people with confirmed epilepsy diagnoses, compared to right now we collect data on all suspected epilepsies. So that will help reduce the data burden further. We're also going to support sub-trust and health board data entry and analyses. So currently you all enter data at trust or health board level, but we're going to introduce that you can enter data at organisation level. So I think this will help split up some services that are merged into one trust but have very different processes and patient pathways, etc. So this is a screenshot, and apologies, it's slightly cut off there, but this is an example of what the patient record will look like on the new data platform. So you can see it looks very fancy with a lot of colours to help people use. So after confirming their eligibility to the audit, you'll go through and complete the various tabs that you can see on the left-hand side to input information on the first year of care for that patient. And you can see the blue circles indicate you still have to complete the question. The pink ticks say that you've done that. And each tab will go pink with a tick on the left-hand side. And you can track your progress with the little dial at the bottom. And then the final tab on this record is the performance summary. So for each patient, you'll be able to see whether they have successfully met each performance indicator. And you can see that by a pink tick on some of them, which is achieved. The little triangle with the exclamation part is not yet achieved. And then you'll get an NA figure if they're not applicable to the performance indicator. And this will help firstly spot any data entry errors you may have accidentally clicked the wrong box when completing the data, and you can correct that really easily before the data submission deadline. But it will also highlight where there are potential gaps in patient care, and again, if you're completing this prospectively, there's a chance for you to rectify those before the full year is up. So then you'll get an organisation view, which I haven't shown in the screenshots, but you'll get some contact details, where you are, how many registrations you've got, how many locked complete case records you've got. But a really nice feature that we've introduced is this clinician-facing dashboard. So this is where you can get real-time feedback data on your performance indicators. And you can see in the table, this will be reported at organisation, Trust and Health Board, ICB, NHSE region, Open UK region, country and national. And these will update every time a patient record is completed. So you'll be able to get that really frequent data and spot any data entry errors that I keep saying, but as well just help you monitor more, track more, benchmark more. So this data will be available in the table and in graphical formats, as you can see on the right-hand side. So next steps, we're really almost there with the platform, and we're hoping to go live at the end of this year. That will invite all participating trust and health boards to start entering real patient data on cohort 6 patients. So that was it for me. Hand over if there's any questions from anyone. I think we do have a fair bit of time now, but if there's anything we don't get to, please do email the team and we're happy to answer any questions or provide more information. But thank you.
See if there's any questions.
Just got a microphone so people online can hear you as well.
Hi, is this on? Microphone?
Yes.
So, William Ashton from Nottingham. So, thank you for that. That's great. You mentioned suspected epilepsy and confirmed epilepsy. Can you say a little bit more about misdiagnosis of epilepsy and how to be able to avoid that going forward?
Yeah. So we did previously have a performance indicator around misdiagnosis, but the only real proxy we felt we could reliably measure was detecting those children who were given a diagnosis of epilepsy, and then it was later withdrawn within the first year, and that was the best thing we felt we could extract from contemporaneous records that would show that. Obviously, to really know whether there's misdiagnosis, you'd need clinical evaluation of children, and that's not something that the audit can embed. The rates of misdiagnosis using that proxy measure were really quite good, and we saw marked improvement over the past few years, such that we got to the point we felt it wasn't really a particularly good performance indicator, because actually performance was good by that indicator. So we've withdrawn that output, but we're still collecting the data around that, so we can still report on it. So it's still in our data set, but we've replaced that measure with things like mental health, and that's been the dilemma for us, because as soon as we get good at something, we've been moving the goalposts to something else. So there's always going to be a gap. We've been chasing the gap, but yeah, I think misdiagnosis is still alive and well out there, and there's still variation, but it's been really difficult to see through the Epilepsy12 lens properly.
Can I ask one more question?
Yeah, of course.
So we've got really good data on auditive structure and process, but how are we going to move to auditing outcomes missing?
Yeah, we're not seeing true clinical outcomes in our data. We had a go at capturing seizure freedom through our data set. So at the date of last update, what was the date of the person's last seizure? And we felt that using very simple data points, we thought that was quite a good way at population-wise to begin to get notions of seizure freedom. The dilemma is the outcomes we're after are not all completed in the first year. You know, we're obviously interested in seizure frequency, but also all the neurodevelopmental and quality life outcomes. And we're only looking at the first year of care. So I think through Epilepsy 12 as it stands, that's really difficult to see that properly. And the work we've been beginning with the PRSB, so the Professional Records Standard Body, is to try and create a minimum data standard that can be embedded in the point of care digital health systems that trusts are using. And those outcome measures are a key part of that journey, so that whenever instead of us just dictating this sort of subjective qualitative view of how people are doing and it being just in a narrative view, can we record outcomes in a proper standardized way and start to see that? And the new platform that Nikki has been showcasing is designed to connect. So obviously we're selling it to you as a usability, instant feedback thing, but actually one of the true drivers behind it is to see whether we can connect, so we can automate data flow and then make that data that's being used at the clinical point of care actually serve other uses, and clinical outcomes is one of the key parts of that. So we need to standardize the way we report seizure frequency, standardize the way we report seizure outcome, and then development, learning, school attainment, quality of life, all those other things that make people have fulfilled lives. We need to be in the mix, but we've got a long way to go for that. Thank you.
Is longitudinal data being so if you have longitudinal data over several years, then it might be possible to add one question: has the diagnosis of epilepsy been revised? So if we can in future development, so if somebody felt that initially the diagnosis of epilepsy was made and then subsequently it was felt that that is wrong diagnosis, then at least we can kind of capture that, and also longer term outcomes as well.
Yeah, so at the moment...
Can you just repeat the question?
Yeah. So, okay. So yeah, it's a question about longitudinal. I think actually it was pulling on this sense of longer term outcomes. We're Epilepsy 12 because we're 12 measures over the first 12 months of care, and now we're 10 measures, and we're being pushed to look at things beyond 12 months. So they're nice challenges to have. We did, when we first designed the audit, we thought we'd go on looking at people's second year of care, third year of care, but the data burden was too high. People were exhausted just putting in the first year of care, so we've stopped there. But as we begin to automate data flow, then obviously you can look at whole lifetime, and we need to look at people into adulthood, into later adulthood. You know, you can't just look at the beginning. You've got to look at the whole life journeys. But do you want to say a bit about longitudinal? Because the way we capture data does allow us to see quality longitudinally, doesn't it?
Yes, definitely. So now we're doing cohort 5 data, and although we've changed a few of our performance metrics, a lot of them stay the same. So we can start to include that and see the progress over time, which I think will be really useful. And then something else we're looking into is more into the health inequality data. So seeing how we can capture that variation, not only between geographical regions, which is what we've done at the moment, but also between population groups. And then the more we have that data, it will be really useful to see that over time, especially as various implementations and projects have been going on to help increase that, decrease the variation, increase the equality. So it's definitely something we can do in future, but it will still be on that first year of care.
Any other questions or questions from online?
Sorry, I just Hannah Evans. I just had wanted to say, very interested in the stats around the education and healthcare plans. I know there's barriers lot of barriers around obtaining and a delay in getting a health and education healthcare plan. I'm just really sort of interested about understanding a bit more about the stats around that, and and whose responsibility really is it to get that underway, really.
Yeah. Thank you. Yeah, so that was a question about individual healthcare plans for schools, for education. And it's so hard as a health professional to see what's going on in schools and understand. And I think equally it's difficult for those in the schools to know what's going on in health. And both really need to be inextricably linked for our young people with epilepsy. But there's a massive disconnect, and it's for no good reason. So I think it can be solved, but you tend to hear more about whose responsibility it isn't rather than whose responsibility it is. And I think it's everyone's responsibility. So I think health with education need to make sure that there's a healthcare plan that's not just a completed form, because that would be easy, it's got to be good, and talk about their seizures, how it affects their education and their participation. So it's not just filling a form, but getting it right and individualised for the child. And we've got to play a part of that in health, because you can't devolve that to school or to the teacher or the Senko. There's got to be a symbiosis. So somehow we've got to make that easier. So even if education could know that the parent has consented for there to be clear sharing of information between health and education on an ongoing basis, that'd be really good if we could just have a way of knowing that consent has been given to share information. If there were more epilepsy specialist nurses, or more in the community with expertise in epilepsy going into schools, and more enthusiasm to get things right for the young people in schools, that would really, really help. And then I think the healthcare plans would be a natural outcome of that. And in health, it'd be great to know what school attendance. I spend my life trying to work out whether a child or young person is really going to school. So seeing that as a really good outcome measure, educational attendance is really important, and we don't see it. And then when the young person brings their school report, or you ask school how is this young person doing in school, I never really understand what they're telling me. The way we compare young people to their peers, to their potential, to where they should be going to an educational point of view, it's really difficult to see whether they're fulfilling their potential. So that whole data sharing between health and education needs solving, because it's a key outcome measure, I think, for us. It's not just the seizure frequency. But I think ICBs can help with that. These things are not unsolvable, and increasingly things are in the digital sphere, and the data can flow, and the barriers are not. They're of human design. The barriers, we can cut through them if there's a will.
I've got a question online. Touched on this a little bit, but it would be nice to go into a bit more depth. Many trusts are now rolling out new IT systems with enhanced potential for data extraction. Is there a scope for Epilepsy12 to be adapted to these systems to make it easier to extract data for the audit?
I'm going to let Vicky answer this.
Yeah, so as Colin mentioned, the kind of idea when we first started developing the new data platform was to form this automatic flow, so develop an API, which is automatic program interface, which will allow data to flow directly from Trust and Health Board's electronic patient records to our audit data platform. So it would cut out the need for manual data entry, and clinicians could, in theory, just go on and kind of double check the data, assure it, and submit, which is the future, but kind of challenges we faced when looking at that. So it is kind of set up in the new platform, but the issue is connecting it to the trust patient records, because it's kind of different for every trust of how they collect their data, and it's hard to find a uniform format or way that we can get the data to flow. So the work that we've been doing with the PRSB would hopefully fix that. If we get standard information developed for epilepsy, then trust and health boards could adopt that, incorporate that into their EPRs, and then link it directly to our platform. So that is the future. We are a little bit of a way off, but hopefully we'll get there.
No, we're in stage 2 of a six-step process with the PRSB, and we're doing it with adults. So we've decided to go on this journey not just with children, but to try and do it as a whole epilepsy community. And so we're trying to create collaboration and consensus, and not just around epilepsy terminology, but all around all those different data elements that build up people's epilepsy story. So you can imagine some of the barriers we have to solve within that, but I think it's doable. And if we don't do that, it's just going to be chaotic. Everyone's going to be doing their own thing. They're going to have their great platforms that do really whizzy things, but the data doesn't go anywhere. It just stays in their bubble. So somehow we need to help make sure the data is standardized so that we can see things outside the bubble. Otherwise, we'll be in an even more complex world of data. Calvin, you've got.
Can I just ask, I think with the PRSB...
Just, I'm going to let you have the microphone.
I'll try and project. Not be so Devonian. With the PRSB work, I think, has the PRSB published a report on the development stage that you've undertaken already? Because that would probably be really good to share that by chat so everyone can see what the focus on working in the stages to be followed and where you're at.
Yes, definitely. So we published the discovery report. Well, I say PRSB have published the discovery report, which is the first stage. So we'll pop a link to that online. But then we're now in the second phase, which is the user-centered design. And that's kind of refining the standard a little bit more, using reference groups of key professionals. And then once we've completed that, we'll move on to the consultation phases, so which we're actively seeking funding for. But it's a comprehensive report of all different elements that could be involved in a record. So it's definitely a very interesting read. And I think it also includes the different standards. You can find out more information on the PRSB website about that as well. Thank you.
And it's, again, we're following in the footsteps of diabetes. So it's amazing how much commonality there is between our data model as it stands and the diabetes data model. And I think we can all see with epilepsy where we're going, with wearables, devices, and diabetes is ahead of that. So a lot of people with diabetes have now got real-time sugar monitoring, and they're beginning to get feedback loops, and that's beginning to integrate into their digital healthcare system that's for them, it's personalised, it's for them. And we're privy to it as health professionals. So I think that's where we're going with epilepsy. So we're, again, following in the wake of diabetes, and we don't want our data set to be over here and just for epilepsy. It needs to be with all the person's other health problems, because we know people don't just have epilepsy, they have other health problems as well. So the story for people with epilepsy needs to be right in the heart of their digital health record. So yeah, join us. So we'll put the link, thanks for the prompt, Calvin, we'll put the link in the chat and we'll share it, and there'll be lots of opportunities for people to join in that data model evolvement over the next couple of years.
We've got a few more questions in the chat, but I will respond to them in.
Fantastic.
Yeah, so massive congratulations to you, Colin, and the Epilepsy12 team. I think it's incredible where starting in 2006 to where we are now with real-time performance metrics, and people can compare how their service is doing compared to, regional and national kind of performance. So it's incredible. So congratulations, and we'll break for lunch now. So we'll be back at 1 o'clock. And for people who are here, the lunch is served in antenatal room, I'm told. I don't know what happens in postnatal room after that. So, all right. So back at 1 o'clock. Thank you.